No, Parker threw up in my hair last night.
He did what?
He threw up in my hair last night.
Did you take a shower?
I already had one.
Thank you.
I didn't get back to get in the shower, but like I did the whole life, you know. I mean, I just think of my body in there, but I washed this all off. She got a little bit in my neck because it was like poltergeist-y. It was like, oh, there's a project. It was everywhere.
She usually watches it.
I got a really good girl. Jalisa, your baby looks so cute and it's gone.
Oh, thanks. Mommy made it.
He looks so
$6 for the set.
Who's his mama? Nah, this
Okay, alright, anatomy of the breast. So highlight the first line on page 550 under anatomy of the breast. Says the breast is a modified sweat gland located in the superficial fascia of the anterior chest wall. Everybody kind of knows where the tatas are. Alright, let's skip the next sentence. Come on, Jalisa. I know, I was just about to say that. You read my mind way on there.
550. No, no, because we don't have the test.
What chapter are you on, Yarn?
Page 543.
No,
I just
550.
opened the wrong chapter.
Well, it caught my
Page 550.
Where are we at?
Volume 1.
Page 550, chapter 21, it's the breast.
Oh, volume 1.
Oh my God.
But you know what, I did the same thing.
We're here.
You blame, I don't have them Jim with the bug down.
Where's that? How we educated? Very nice.
I know it, I have to park in the mud whenever I'm playing football.
And Jim
They got no real parking lot.
We wasn't in prison.
Okay. Alright, in many women, the breast extends deep toward the lateral upper margin of the chest and into the axilla. That's your armpit. So not going to say in your armpit. And then the extension of the breast tissue and going up into it is called the tail of Spence, or the axillary tail of the breast. And it's kind of demonstrating it there in figure 21-1.
I didn't know that had tail.
It can, not everybody has breast tissue that goes like right here. Some do. Look, everybody's trying to steal it.
Breast done, it goes up there. She has to massage them down.
Her implants do.
They automatically not go up. The tail of
She
the
has
breast.
silicone.
Look at your picture.
No, breast has tail.
You don't,
But she always had to.
goes up in your neck.
Yeah,
You don't have your book there?
Oh, that's right, I actually had it. Yeah. What is it?
I said, got it when she had her book.
Okay, well, I Yeah. didn't catch
Well,
that
put your
part.
book out.
Well, I mean, I have big boobs, so I mean, that's why.
You need to get your book
Go
out.
all there.
I'm just saying, we're sitting there talking about.
Emily's over here.
I don't understand why people want to get boobs.
No, take mine out.
Alright, the surface of the breast is dominated by the nipple and the surrounding areola. Everyone knows what the nipple is, everyone knows what the areola is, right?
Really good.
Yes, that's the red thing.
Lord,
Red. Okay, you're the
Should I stop the recording?
Okay, a few women can have ectopic breast tissue, and this is usually located along the mammary milk line. That's where like the third nipple thing comes along. or 4. I mean, you know, you have a little extra, but that's the ectopic breast tissue. And then you go the law of the mammary gland, which is this right here. This is your little nipple.
Those are her extra nipples?
Yeah, those are her extra nipples. She's got a few of them. But then this is where the tail of spit can kind of go up into her armpit.
So do those extra nipples, do they have milk coming out? Didn't James Bond have an extra nipple? Super nipple. What kind of question?
Wow.
I don't understand what a memory is.
Yeah, what's the milk?
She did.
I mean,
She said it on her American Idol interview. She said that.
Who?
And like, we understand you have something unique about you, and she's like, yes, I'm so nipple.
Did Chandler on Crim?
I wanna know you. Who is that one? Anyway.
Carry on your one. Okay. There are 3 layers to the breast. Hold on. So sonographically, the breast is divided into 3 layers. It is this subcutaneous, which is the most superficial. And would I hope you're all right?
no, I was inhaling my gum the other day.
Okay.
She said, I wonder if it gets hard.
Oh.
And then the gum got stuck in the back of my throat.
So did you swallow it?
No, I got it.
Okay.
We don't know time.
Okay, and then you got the mammary or the glandular layer. That's like the main portion of the boob. That's the one that varies in its size depending on how big your boobs are. And then the retromammary, of course, just in its name, it's retro behind mammary, so it's going to be behind the mammary layer, or the glandular layer. So this is from superficial to most deep, to deepest. Alright, the subcutaneous and retromammary layers are usually quite thin. So both of these are thin, whereas the mammary layer is the thicker one. And they are often highly echogenic and surrounded by connective tissue. Fat, so you guys know just from scanning before, fat is usually very echogenic in other parts of the body, but in the breast, it's actually hypoechoic. So it's opposite. Fat in the breast is hypoechoic. Alright, and then so just highlight the rest of that paragraph, the one where it says sonographically the breast is divided. Highlight the rest of that. Make sure you get where it says fatty tissue appears hypoechoic. Alright, so the mammary of the glandular layer includes the functional portion of the breast. This is the main portion of the breast. This is where all the function of it occurs. And also the surrounding supportive tissue, which is the stromal tissue. So just like in the ovaries, that extra tissue that's around the follicles, that's that supporting tissue, that's the ovarian stroma. You kind of heard me say it before, right? So you should have anyway. Alright, the functional portion of the breast is made up of 15 to 20 lobes. And these contain the milk-producing glands and the ductal system, which carries the milk to the nipple. Alright, now the upper outer quadrant of the breast contains the highest concentration of these lobes. And that's like the reason why most tumors are found there. So most abnormalities, most tumors are going to be found in the upper outer quadrant, and it's because that's where most lobes are located. Now the major duct branches into smaller branches, okay, I did that twice, into smaller branches called lobules. Each lobule contains acini, and the acini are the milk-producing glands. Like the acini in the pancreas, those are the pancreatic juice-producing glands, but in the breast, it's the milk-producing glands. Alright, on page 550, highlight the paragraph where it says the mammary glandular layer includes the functional portion. Highlight those first 2 sentences. Highlight where it says 15 to 20 lobes. Highlight the sentence where it says, skip the next sentence, highlight the next one where it says the upper outer quadrant of the breast contains the highest concentration of lobes.
I have no idea.
Page 550. And that's the reason why most tumors are found here, as most tumors originate from within the ducts. Alright, move over to page 551. It says the major duct branches into smaller branches called lobules, and each lobule contains acini. You need to know what acini is. That is the That's what actually produces the milk.
Are you, measured in breast too?
No.
So breast is separate, you said?
Yes. That's why we're not super focused. We're gonna do the basics and how to scan it.
So you what?
Because breast, you don't always do breast wherever you're, like at my first job, we did a ton of breast, but not at my last 2 jobs.
So it's something that you just learned as you did, or you already knew?
I mean, we did the book work, but we didn't scan any, so I learned to scan breast when I was out there working. But you can scan your own here if you want to. Or if you get a buddy that wants to let you scan their book, you can. Okay, alright, so let's get down where it says the terminal ends of the duct and then CNE forms small lobular units referred to as terminal ductal lobular units. This is the terminal unit. This is the end of it. This is like the smallest part of the ductal system. And they usually measure 1 to 2 millimeters and usually are not differentiated sonographically. Like you can't see these because they are so small. But the reason why these are significant is because most pathologic processes that occur within the breast originate there. Where most pathologies originate in the ducts, in that ductal system, most specifically in the TDLUs, or the terminal ductal lobular unit. Alright, so let's get down 2 sentences where it says the connective tissue septa within the breast form a fibrous skeleton. And that skeleton is called Cooper's ligament, and that's responsible for maintaining the shape and structure of the breast. You know Cooper's ligament. That's the fibrous skeleton of the breast. Alright, next page. Alright, down to sonographic appearance. Or actually, let's highlight that first sentence on that first page where it says the pectoralis major muscle lies posterior to the retromammary layer, because you're gonna see that whenever you're scanning a breast. So you got your muscle layer. So whenever you hear about breast augmentations, you can have implants in front or behind, so anterior or posterior to the muscle. So that's the muscle that they're talking about, and you'll be able to see it on ultrasound. Okay, going on to sonographic appearances. Alright, now the internal nipple, it may show low to bright reflections of posterior shadowing, and it has a variable appearance. You'll see it'll look like there's a lot of shadow going over it whenever you take the probe and go over the nipple. Even if you have plenty of gel, there'll still be like a shadow that kind of casts out there. Let's see, subcutaneous fat generally appears hypoechoic in the breast, again because fat appears hypoechoic in the breast, whereas Cooper's ligaments and other connective tissue are echogenic and are dispersed in a linear pattern. So instead of these bright white lines, they'll just kind of go. But you'll have to kind of have your probe in a certain way to let you see them lengthened out, and that's Cooper's ligament. Alright, down to the mammary glandular layer, next paragraph. That lies between the subcutaneous layer, which is anterior, and then the retromammary layer posteriorly. The fatty tissue is dispersed throughout the mammary glandular layer. It dictates the amount of intensity reflected from the breast. So someone that has very little a little fat in their breast is going to appear very echogenic, whereas if they have more fat, it's going to appear hypoechoic. So we're in the breast, fat is hypoechoic. So you got fatty breast, your breast tissue is going to look more hypoechoic.
Black, which is.
Okay. All right, moving on to 553. Highlight that first 2 lines where it says the retromammary layer is similar. It's similar to the subcutaneous layer. Boundary echoes resemble skin reflections. Pectoral muscles, low-level echo, that's what the muscles are going to look like. They're going to be kind of hypoechoic. And then you'll also be able to see the ribs. If you get your depth low enough, you'll see the ribs. And so you'll see hyperechoic rounded structures and then dense posterior shadowing. So it's just like whenever you look at bones on ultrasound, you're going to set that bright white echogenic line, and then it's going to get all the shadowing behind it. You can't see anything else because the bone absorbs all the sound waves. All right, so here is this is like all the layers here for you. On here, this one's called the pre-mammary, but that's also the subcutaneous. It's just the most superficial. And so you can kind of see just how it's kind of fat, and you've got the hypoechoic. And then this is the mammary layer. This is the glandular layer. So this is someone with relatively small breasts. And then you get your retromammary layer. So you see how it's kind of darker there. And the pectoralis muscle is also hypoechoic. And then you got your ribs. Well, you just have one here. If you can see, it kind of looks like little train tracks, but they're not picking up all of them. So you got your little bright white line and then all the shadowing behind it. So those are your different layers. And different people are going to need different depth settings. Someone with size B's are going to have a different depth setting than someone with A's. Okay, so here's the layers of the normal breast. You got your subcutaneous, your mammary. What's this one? And then you got some muscle, a little bit here. What's this right here?
Rib.
Rib. Kind of makes me think it's one of those 7-layer casserole things. What are you calling things?
No.
Okay.
Don't relate that.
I guess.
A rainbow cake.
Rainbow cake. Okay, here's another one. This is normal breast tissue. You get your subcutaneous layer, your mammary layer, your retromammary layer, your muscle in there, and then I guess this is rib. I don't know. I can't really see rib right in here very well. Maybe there. Under there. Alright, so here's another one. This one is actually in your book, so you guys can go back and look at it. You got your subcutaneous fat layer, your mammary layer, got your retromammary layer, your muscles in there, and then the depth has cut off the ribs. Because you don't have to show the ribs. As long as you get down to it and you show someone like the muscle there, you don't have to show the rest, all the ribs. Because then you know that you got all the breast tissue in there.
Well, that doesn't look very defined to me. The muscle versus the retromammary.
Yeah, it's because it's all
They
hypoechoic.
look the same.
Okay, so the glands are in the subcutaneous, right? Are those the little?
No, that's the mammary. Another name for the mammary layer is the glandular layer.
Yeah,
This
okay.
is the functional layer. Everything else is just kind of hanging out, not going to do much.
So what are those, in the subcutaneous layer, what are those little pouch looking things?
Like this, that's just fat loads.
Oh.
Fat tissue.
What kind of can the boob on? Small parts?
There's actually one that it says breast, small part. That's what you use.
Big part.
Give me your food.
You don't want them, do you?
All right, crankable pattern. Okay, wait. All right, so we're on page 553 on the second column.
Generally.
The second full paragraph, where it says generally in a young woman, fibrous tissue element, it's usually a dense echogenic pattern. Where? Please don't get a full. Illinois. Illinois. You calling me? Okay. All right, and then in a pregnant or lactating woman, the glandular portion will proliferate, the density and volume, it'll appear less echogenic. I actually have a picture of it later in the end. I'll show you guys what all that looks like. But you can have, you'll have some that'll come to you if you work where you have to do a lot of the outpatient stuff. A lot of younger, you don't get memos until you're 40. And so,
Which is crazy.
yeah. Well, they'll have to come in for ultrasound if they're younger, and when someone that has very dense fibrous tissue, and that's just how their breast tissue is, it'll be real lumpy. It happened. My cousin was like, I gotta go to the doctor, my boobs hurt, and she's 16, and I was like, well, let me just feel them. And so you feel them, and they're all lumpy, bumpy, but it's just dense tissue, and it can And they kind of bother them and cause them to worry maybe they got something wrong, but it's just
Cause I
different.
used to have one every time my period came on, it was wrong, and then it'd go away the period. and then
Wasn't
come
that
back.
a 5% breast?
Yeah, I was about to say, it might be cystic.
I was a kid, I thought I had one.
No, okay. Alright, vascular supply. The main arterial supply to the breast comes from the internal mammary and the lateral thoracic arteries. And then next page, venous drainage is provided by superficial veins. And sometimes these veins can become enlarged. But don't get them confused with cysts. These are them there. It's in your book, also on page 553. They're superficial surface veins. Oh my goodness. And you can tell those aren't cysts by there's what?
I was just broke.
Yeah, you can elongate it. Yeah, you can compress them if those are veins. What else? Put color on there.
Blue.
Oh, I got it.
You were just there.
They were like lengthen it out, stretch it out, compress. I mean, that was good, but I could just put color on it. Okay, lymphatic system. Alright, so the lymphatic drainage generally flows to the axillary lymph nodes. Those are the lymph nodes in your underarm. Nodal status affects the patient prognosis. This is really with anything, whenever someone finds out like they have cancer or something, then they want to check the lymph nodes to see if it has spread, because once it gets those lymph nodes, it's going to go throughout the lymphatic chain, which follows like the aorta and the vessels.
Yeah, I don't see that.
It's down in the second.
Yeah,
Second.
under the par standard, it's 1, 2, 3, 4, 5.
Oh, okay.
Y'all don't have a look stuff. Well,
I just don't get it, okay? And when you have a problem, we listen to your problem.
Well,
We struggling to highlight.
well.
All right, page 556. The male breast. Normally, the male breast does retain some of the ductal element beneath the nipple, but it does not develop the milk-producing lobular and acinar tissue. So it does have ductal elements, but it doesn't produce any milk. Due to like hormonal fluctuations or a disease process, or maybe with the medicine that they're taking, they can have hypertrophy of these ductal elements. They can enlarge, and then the man can grow boobies, and that's gynecomastia. Have you ever heard the commercials about you take such and such, and you grow male breasts? That's it. That's a gynecomastia. And breast cancer, it is rare in men. Only about 1,300 new cases are reported each year in the U.S.
Okay.
I've had to scan a few male breasts. Okay. Physiology of the breast. The primary function of the breast is fluid transport. See your babies.
Ooh, and it hurts.
It does hurt. That's why you get that Lexanol.
Have you agree? And agree with us?
No, it was, what is it?
Yeah.
Yeah, whatever, it's not purple tube.
Yeah. They just kept telling me to put some grease stuff on. I use the nipple shield in there.
I thought it was linoleum.
It is.
Linoleum, yeah.
Any way you want to pronounce it.
I just thought it was L.
I didn't understand.
But that purple green, that is like,
Yeah.
I have that shield too, that shield hurts.
The shield hurt. Oh, it's all y'all doing.
Okay. Alright, so over to page 557, down in that first full paragraph, which is an important function, don't highlight that line. Highlight the next sentence.
Milk.
Milk is produced within the acini and is carried to the nipple via the duct. So again, the acini is what actually produces the milk. Alright, skip to the next page. Alright, go down, highlight that last sentence in that first one where it says prolactin is a hormone produced by the pituitary gland that stimulates the acini to produce and excrete milk. So the acini produces the milk, but the acini is told to produce the milk because of prolactin, which is a hormone produced by the pituitary gland. Alright, now let's skip like a whole bunch of pages. Because everybody knows about checking your boobs, and we'll hear all the time. Alright, on page 564, you don't have to highlight any of this, but when you think about it, like for someone to go get a breast ultrasound, what's like the first sign that they're gonna be coming to you for? They found the lump, yeah. And so if someone's coming to you, they're like, I feel a lump like right here, you know, you can actually feel it, like, well, show me where it is, you know, with gloved hands, just because it can get creepy if you don't have gloves on your hands. Just feel it. No, seriously, because I was kind of creeped out because the radiologist did it barehanded. I was like, oh God, you're a man. Like, I'm a woman. I don't know, it was just kind of weird to me. Just wear gloves. I don't know, it kind of takes the creep factor out. But you can just feel on it and feel how big it is, and then you can just put the probe right in. Okay. And then most masses, most nodules are fibroadenomas, which we'll talk about. So let's keep skipping a few more. Let's move on to 568 under positioning. So patients are usually scanned in supine position, so you're laying on their back with their arm behind their head. So if you're going to be scanning the right breast, you're going to have them laying down and they're going to reach their right arm up and just kind of hang out like this, like you scan their
Page 568,
568,
second column.
under position.
Yeah, just highlight the first two lines.
Positioning is like gold.
Okay.
Yeah, highlight the first two sentences. And then if you're doing the left breast, you just reach that left, have them reach their left arm up like this, and then you would scan.
Check the breast.
Alright. Alright, so with scanning, you got a sagittal and transverse, but with the breast, you also have radial and anti-radial. And it's got a table or a figure here for you on 569 to kind of show you it. So sagittal still is straight, you know, just like this. Wherever it is, you're like this. And transverse, you're like this. But you think of the breast like a clock. And so now you've got radial and anti-radial. That's where this comes in. It's like you take and you need to make sure whenever you're scanning a breast that you're doing it however that everyone else in that lab is doing it. Everyone needs to be on the same page. Or else you're going to make a mass, the measurements not measure right. Or they'll look different. And you don't want to do that because they'll come in for like follow-up ultrasounds. You don't want the measurements to be different. And so radial is where like you would start at like 12 and then you would just kind of scan the probe around. So eventually your probe ends up being backwards. But you just go all the way around. And that's when like you do the sweep through the breast. And you would just kind of sweep through and then take your pictures, you know, like freeze, print, and take your pictures that way.
Take all those pictures on the road.
We would do, if we were just doing like a sweep, we would do, this isn't for every site, I don't know, some people may do it just like that, but where I was, like at Citizens, when we were doing it then, she would let us do, it would say like 12 to 3, and then we would scan through there, and then it would say like 3 to 6, and then we would scan through there. And then whenever we found a mass, we would stop and say, okay, it's at 2 o'clock, and then we would take like all of our pictures. But usually they come to you, if they're older, they come to you from mammo. So they're like, well, we saw something at this area, so if you can just kind of look at it right there. So you can kind of hone in and kind of know where you're already looking. All right.
So what is anti-radial then?
That's like the opposite. Like if radial is like, if you're going around this way, and this is your radial, your anti-radial is going to be like the opposite of that, perpendicular to it.
Did you get a roof to throw it?
No, I was just making sure. Smells good. Smells like rabbit. No, pomegranate. Alright, so say like this is the boob, and you're scanning around, this is like your clock, and this is your radial. Because you're scanning around and you're like right here, your anti-radial will be perpendicular to that. Okay? And so if someone measured a lump in radial and anti-radial, but then someone else came over here and measured it in long and transverse, it's probably going to measure a little bit differently, unless it's like a perfect spherical cyst. But if it's some kind of mass that looks like this, like the measurements are going to be different. So you don't want that. Okay. So that's sagittal and transverse, and then you got your radial and your anti-radial. And then the breast is also divided up into quadrants. And that is in figure 2128. You've got your right upper outer quadrant, right upper inner. And so it's just dividing into those 4, and then also it kind of looks like the clock face, and that is showing you that picture right there at the bottom.
So these like all,
Huh?
these like all these awareness, like, you do all of them.
However, the lab is that you're in, that's what you would use. We always did the clock, and then we would say it's, you can use the quadrants if you want to. Some people would just say, instead of saying like 12 to 3, they would just say like right, upper, outer, or whatever, and scan it like that. So just do it however everybody in your site is doing it. Like I said, she had us label 12 to 3, and then we would scan through. But I like the quadrant one better. Alright. Okay, next page. Okay, so there, okay. So here's another picture. This kind of tells you the layers. Right here, and you get your muscle, and then your rib, and then you come to lung. But then you got your 3 layers of the breast, which this, what is this one?
This is
Subcutaneous. Yes, very good. Alright, and then, so you're gonna, we can see on this, but whenever someone's, like if a doctor's gonna go and like biopsy the breast, then you know exactly where it is. So they're gonna be like, oh, it's the mammary layer. Okay, well, where is the mammary layer? Like, okay, 3 o'clock, but we need more. So another way to do this is, this was like the mass here. You can say this is like at about 1. So we know that it's closer to the nipple instead of further out at about, I don't know what, 5 o'clock. So say there's a mass at 5 o'clock. Well, it can be anywhere along this line, so we're going to say, oh, well, it's at 1, or it's in that first little circle. And then also another thing is the depth of it. You can see how deep it is. And this one is superficial, so you would say it's A. Okay, so it'd be like in 1A or A1 or whatever. And this is just saying, because, you know, the mass could be right here. So this is just letting us know, like, how deep the mass is, and then how close it is to the nipple, as well as at what time it is. Like it's at 5 o'clock. And then it's close to the nipple, and it's very superficial. So with these,
So you would have like a 1A 5 o'clock.
There.
Yeah, I'm just saying.
Yeah, that's what that would be, right?
It says on the board.
I'm just trying to.
Emily,
No.
I'm thinking it out. I'm thinking it out.
that's okay, so think it out, think it out.
Bring it on down.
Yeah, and a lot of times you ain't even got to use all this, because it comes to you straight from memo. And they know where it is, they just want to be able to see, they want to know what the consistency is. They want to know, is it a cyst, is it solid, does it have vasculature to it? So a lot of times you ain't going to do this. Okay. Alright, so moving on to sonographic characteristics of breast lesions. So just, it's on page 570. You guys can just highlight, because you guys already know what a cyst is supposed to look like, right? A cyst they are usually considered benign. Down in that second paragraph, a simple cyst is supposed to be anechoic, supposed to show smooth inner margin, posterior acoustic enhancement, supposed to be round, our parts. That's what a simple cyst is supposed to look like. And then a complicated cyst or a complex cyst, you'll have septations, internal echoes, or the walls may be thickened, slightly irregular. But it's still a cyst, it's just slightly complicated. It's got some issues. Alright, page 572. Let's go down to margin, page 572. Alright, under that second full paragraph, under margin, where it says malignant tumors, the second sentence, malignant tumors are aggressive and tend to grow through tissue via finger-like extensions called speculation. And so they're not nice and rounded, they're going to like extend out and go get in everybody's business and be invasive. Hang on, I got some cysts. So here's a simple breast cyst. Here's a simple breast cyst. Here's a simple breast cyst. I mean, a cyst is a cyst.
Yeah, got it.
Here's a complex cyst. There's a complex cyst. See, there's just some echoes in there. And what are some things that can cause echoes?
Your game.
Huh?
Your game, can it?
What?
Well, it
Oh.
makes it look like it. That's gonna be my problem.
Okay, yeah, game. Well, what else?
Breed,
Like,
I mean, not breed, but,
hemorrhage, blood, what else? I mean, yeah, but those aren't complications. Infection.
pulse, not pulse.
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 Oh, pus, okay. I said, a pulse and a pus, Larry? Oh, Lord.
He has a heartbeat.
Yeah.
Okay. Alright, so, again, so in benign, tumors or stuff, they're usually smooth around and malignant. They're going to be indistinct, kind of fuzzy, speculated. They're going to be real irregular shape. Disruption of breast tissue. Still on 572. Benign tumors are slow growing and they don't invade the surrounding tissue, whereas malignant are opposite. They grow through the tissue and they don't compress adjacent structures, whereas the benign tissues do, or benign issues do compress the other structures, so they're not actually getting like into that tissue. They're not invading that tissue, whereas the malignancies are. And then malignancies can cause, if you go over to page 573, that first full paragraph says malignant lesions tend to grow right through the normal breast tissue. And as the malignant masses enlarge, they may cause retraction of the nipple or dimpling of the skin as the spiculations pull on Cooper's ligaments. So they can pull on those Cooper's ligaments, which is like the skeleton of the breast, that fibrous skeleton, and it can cause dimples to occur in the breast, or the nipples actually retract into the breast. All right, the shape, benign tumors are usually, benign issues are usually round or oval, whereas malignancies are sharp, angular, kind of microlobulations. They're not going to be real, like a big, large lobe. Orientation, malignancies, if you just remember taller than wide, about when it comes to breast malignancies. If you see a malignancy in the breast that looks like this, is that probably going to be benign or malignant? This would be benign. This one would be malignant.
Okay, 'cause it's taller.
Oh. Yeah. So taller than mine. I always was thinking like someone shorter wouldn't be able to like, I don't know, like shoot me up or something, and someone else that's so tall and like, yeah. Okay, and then internal echo patterns. So benign neoplasms are isoechoic and hyperechoic, whereas the malignancies are usually hypo. And then they can have microcalcifications. Alright, so microcalcifications are kind of a characteristic of a malignancy. If you see a hypoechoic structure or mass in the breast and has microcalcifications in there, you're going to be like, oh, that's malignant. Okay, and then attenuation effects. In benign tumors, there's going to be posterior enhancement, whereas in malignancies, there's going to be strong attenuations. There may even be like shadowing instead of enhancement behind it.
Hold on.
I know. 574.
574, enhancement, posterior.
It's the second, or the first one, enhancement behind a lesion. Then you go down there to put.
You want to know something? On page 571, that box is, that's what it says. That box is like,
No.
3 pages later.
Which box is it?
The one 2111? Box 2111. That's all of that right there. Just to go.
Okay.
I just want to make y'all sweat for a little bit. Make sure y'all paying attention.
Oh my goodness.
Well, it works. Alright.
It works.
You probably do this all the time.
Okay. Moving on to pathology. Wait, nope. We didn't finish that yet. Alright, mobility. Benign tumors have a little bit of mobility, so if you kind of push on them, they can like move around just a little bit. And the malignant tumors, they are firmly fixed, just because they've already invaded wherever they gotta go. And so they're not going to move. Compressibility. Benign fatty tumors usually are compressible a little bit, whereas malignant ones aren't. vascularity. Malignant tumors are going to have a hypervascular, they have like a feeder vessel, because malignancies need all that blood to grow and go get in everybody's business. Okay, pathology. So just know, cysts, those are commonly seen. You're going to see breast cysts all the time. If they're a simple cyst, then you're just like, okay, you can go on home. Well, you don't say that, doctors don't say that. But they're just like, check up on this. All right, fibrocystic condition. This is something that younger women can have too, and it's where the breasts are usually like pain and tender, and it's usually just during like that time of the month because of the hormonal fluctuation. And on ultrasound, it's just going to look like a lot of cysts, quite a few cysts throughout the breast. All right, now fibroadenoma, that's the most common benign breast tumor, and it appears hypoechoic on ultrasound.
It's 575. Oh, wait, which one are we on? Yeah, 575.
565, highlight the first line. So the most common benign breast tumors are fibroadenomas. This is what you're going to see a lot of. If it's not a cyst, chances are going to be a fibroadenoma or to be breast cancer. All right, flip the page. All right, and highlight that first line where it says fibroadenomas are normally hypoechoic. But if there's fat within there, or sometimes they can be hyperechoic whenever it's around like a lot of like fatty tissue. If you have like a very fat breast, then it may actually look hyperechoic instead of hypo. All right, so a lipoma, that's a fat tumor. Smooth walls, and on and in the breast they will appear hypoechoic. Okay, and then fat necrosis. Just sonographically, fat necrosis appears as irregular complex mass with low-level echoes, and this is usually due to like trauma, surgery, radiation, something like mastitis, something that causes the fat to actually necrose. And it'll look all icky like something, like some kind of malignancy. Put color on there, no blood flow will be there because it's necrosed. I mean, it's dying, so it's not going to have any blood flow. All right, acute mastitis. Mastitis is inflammation of the breast. But whenever it's inflammation of the ducts, it's considered acute because that's where like everything tends to start, is in the ducts. And it very often occurs during lactation. You may hear someone that's trying to breastfeed, but they develop mastitis. And it causes the breast to become enlarged, real red, and then tender. Chronic mastitis is considered chronic if it's inflammation of the glandular tissue. So it's like it's kind of made its way out of the duct and into the glandular tissue. And it's hard to tell that on ultrasound. Abscess, we all know what an abscess can look like. It can look all different ways. It can be completely cystic. It can be cystic with some echoes internally. It can appear completely solid, have irregular walls, and have kind of be rounded shaped. But abscess causes pain, swelling, and reddening of the overlying skin. Patient may have a bit of a fever, and they may even have swollen, painful axillary nodes because this is infection. So infection, the lymph nodes may swell up. And then hyperemia, that's hyperemic blood flow, so it's going to have increased blood flow because it's infection. And so, I've had to scan an abscess before on a breast. Usually you just have the patient, well, this one actually had like a really big boob, but I just have her hold it up, actually. If you have someone that does have like the really large breast, you might just have to prop it up with some towels and stuff, or you can just have them hold it. She offered to hold it, so she just held it out for me. Do what? It wasn't that bad. We got like 4 people trying to hold it up. But okay, let's move on. Okay, so here is just because fibrocystic. These are just going to look like cysts. You saw a bunch of pictures of cysts earlier. So this is just going to look like different cysts. But this is like what a normal tissue breast is going to look like. It's your subcutaneous, your mammary, your retro, your muscle, and then your ribs. Over here, we've got a bunch of cysts in here. And so this is a fibrocystic condition. so here is a fibroadenoma. See, this hypoechoic hanging out in the mammary layer. See, and she's got a subcutaneous layer. Our retromammary, got a little muscle back here and then a rib. All right, here's a lipoma. See how hypoechoic it is? Here's some fat necrosis. See, it looks kind of icky, right? You put color on there, it's not going to light up. All right, so here's mastitis with some edema. You got like that little ant farm appearance that you will hear about whenever you talk about edema in the legs. You'll get some, you talk about the cellulitis and stuff. Well, you can get edema in your boobs too, and that's with mastitis. All right, so here is just a normal lactating breast. You can actually see all the ducts here. This is actually normal just because she's got milk in her ductal system. All right, here's a breast abscess. This is one way that it can look, an abscess can look. All right, pathology. This is like our last slide. No, okay, this is our last slide before pictures and that's it. All right, so we're just going to go over these on page 578. This is all that I want you guys to highlight. Just these sentences. Under the ductal carcinoma in situ, these are cancer cells that are just in the duct, and they haven't like gone through the walls and gotten into the fatty tissue just yet. So if it's in situ, it's just in that one area. Same thing goes for the lobular carcinoma in situ. That's just going to be in the lobule, whereas the ductal in situ is just in the duct. And then the invasive ductal carcinoma, that's the most common type of breast cancer. Like 80% of breast cancers are IDC. And they start in the duct, and then they do invade the fatty tissue. Whereas the lobular, again, the situ, that's not considered a cancer. It's considered precancerous growth that begins in the lobule and is confined to the gland. And then invasive lobular carcinoma begins in the lobule, and then it does extend into the fatty tissue of the breast. So the invasive ones, they spread out, they spread their wings and go other places where they didn't start. Whereas the in situ stay where they are. Lobular in situ stays in the lobe. Ductal in situ stays in the duct.
But why do they call it carcinoma if it's not considered?
It's precancerous. I guess that's why they still give it that name. Because it can turn into cancer. All right, and then, you know, there's carcinoma, juvenile breast cancer, papillary carcinoma. All these are like subtypes of these. They all fit into one of these. And most of these are invasive ductal carcinomas because most of them start in the duct. So we're going to skip all that because that's histology. That's for the pathologist. And then the ultrasound-guided interventional procedures, and we all know about needle aspiration. You know, ultrasound is used to actually get a biopsy of the breast tissue or whatever mass that is. That's really all for that. And we'll just look at some pictures. So here's a cancer. That's invasive ductal carcinoma at, look, 2 o'clock. Here's another. This is another ductal carcinoma. Here's another. This is an invasive lobular carcinoma. All right, so here are those microcalcifications that you see in like a hypoechoic mass. So you know that's going to be malignant. All right, and then this is just the only picture that was really good that you'll need. Whenever you use the ultrasound, you'll kind of show the lesion or the target lesion, and then the needle will come in. And you'll actually be able to see the needle actually going into the mass. Okay? Okay. All right. Let's do your open book test now.
Did you ever got an award? No. Where have you been?
I thought she even said it. I don't know when I'm hearing nothing anymore.
She's in the front row.
I know that. And they are always like, she said that.
You can write on the paper. Be sure to write your name.
This is open book and conversation.
No conversation now. But it is open book. And because I was feeling nice, it's in order. So you don't have to flip back and forth between the pages.
That's very sweet.
I know.
all.
Yeah.
Oh, no, sometimes I haven't been feeling good, and I'm just ready for the brain. I appreciate you. How's it going?
For the fibroadenomas, are you looking for the normally this or occasionally? Or 17?
17, what do they normally look like? There's no homework, just study for the summer.
Are we gonna have another scan soon? We are gonna have another scan. Ready, my sister? Oh, yeah, what did yeah, I know it's supposed to be just right. Did I have the right one the first time? Oh, yeah.
So you want to look at. Oh, no.